the workshop here. We've got, this is about our anaesthetic visiting lecture programme, and what we want to show you is really how we set it up, what we've done, and how potentially other specialties might want to become involved, and if it's something you might see your trainees wanting to do. I'm going to just give a bit of a 10-minute chat on how we set it all up in the first place, and then we've got two of our visiting lecturers who've been out there are going to give us what their experiences were and how they actually found it and whether it was valuable to their training. And then at the end, Ali, who's also been out there, is going to talk through how we're looking at getting further funding for the programme and how potentially we can bring in other specialties because of the great need out there. Now this visiting lecture programme came from basically a partnership between three organisations, Operation Smile, Jima University and KSS Deanery. So I'm just going to quickly go through a couple of them. I mean, I've worked as a volunteer with Operation Smile for about 20 years now, and I set it up in this country about 10 years ago. But out of this slide, I just want to look at these two key areas here, global standards. Operation Smile has always had a ethos that whenever they operate on a child in a developing country, that child should be operated on to the same standard that they will get operated on in their own country. So when I go around talking about Operation Smile to everyone, all the trainees go, oh, I'd love to do that, I'd love to do that. But Operation Smile only actually lets consultants go. So it's quite frustrating that I have a lot of very enthusiastic trainees who want to go and work overseas. I can't offer them anything. Giving you an idea of, this was 2 weeks ago actually, 2 weeks today, we operated on this little boy called Baruch, and he's got a very basic cleft lip, and this is him literally 3 hours afterwards. So he went from heading towards a completely abnormal life to a completely normal life in the future. That will look absolutely perfect. Now his parents had travelled 48 hours, he was 7 months old, on the off chance he might get surgery. Fortunately, we managed to be able to do it. Now I say we managed to be able to do it, that isn't actually strictly the case, because if I dissect this slide for you here, this is Baruch on the table, this is Johannes, who has done 4 years of surgery and is now a consultant in general surgery there. My colleague Per Hall, who comes from Cambridge, trained him how to do a basic cleft lip last year. He is there training his trainee, who has done 3 years of surgery, and that's Rahama. So she actually did that cleft lip. So now we've got an Ethiopian that we've trained to do a procedure, training another Ethiopian to do a procedure. Here we have Tesfaye, who was one of the operating scrub nurses, who we'd also helped train over the previous years. And here's a really good friend of mine, Million, who's actually equivalent to a kind of nurse anaesthetist, a graduate anaesthetist. And I first met him when he was 19. He'd gone straight from school to train just to do anaesthetics. And I've been helping in his training for the last 6 or 7 years. So that whole procedure there is being done by Ethiopians on the Ethiopian channel. Now that wouldn't have happened a few years ago because the skill set wasn't there to do that. And I suppose that gives an idea of the flavour of the kind of things that we're trying to achieve. And of course the result is an extremely happy mother who's got another 48 hours travelling back to the place they came from with a perfectly normal child. Now, going on to the second part of the partnership, Jima University, out of this slide, I just want to pick out here, when I first went to Ethiopia in 2005, there were 3 medical schools and they were producing 300 doctors a year. Now, for a country that has a population of 4 million, producing 300 doctors a year doesn't seem as though it's going to provide a health service. Well, it doesn't, clearly it doesn't, being as we provide 7,000 doctors a year and we can't provide a health service. Now, if we go to 2012, we've got 14 medical schools and 4,000 doctors being produced in Ethiopia. I didn't believe these figures. I've checked them over and over and over again. That doesn't seem to make... How do you suddenly get another 11 medical schools? Who's doing the training? Well, the government just decided they wanted to produce a whole load more doctors. And what's actually happening is that they're producing an awful lot of doctors and very few people in place to do the training. And there was an obvious kind of position where you might think that people coming from overseas to actually provide training would be really a useful thing to do. Which takes me on to Jima. Now this is back in 2005. This is the sign outside the main hospital, covering a population of 15 million as a regional centre. And this is the main sign. It's not even straight, the writing on it. And at the time, it only had 3 telephone numbers. It's difficult to kind of get those numbers into perspective, really, isn't it? That sign isn't there anymore. When I was there a couple of weeks ago, it's fallen down, unfortunately. But they are building a brand new hospital, which was due to open in 2010, I think. I think it's, no, 2011 it was due to open, and we're in 2014, it's still not open. But it's getting there. I'll get a bit on my hobby horse, because it really upsets me, this actually. This is actually Jima. This is where coffee was discovered. There was a little goat herder called Coldy who used to live on this hill up here. And there's a little kind of monument with a kind of little seat, stone seat, where he used to sit. And he fed, well, he didn't feed, he saw his goats eating coffee beans and saw them jumping around, so he thought he'd try it. And hence, that's where coffee was discovered. Now, if you look here, this is Sunday afternoon, and these are kids living where coffee was discovered. While doing the Sunday washing in a river full of bilharzia. Here, kids here, 1 in 10 of them will die before they're 5, and majority of them will not reach the age of 50. And that's how they build a road in Jima. Now, it seems rather sad to me that every other shop, well, certainly where I live in Chichester, sells coffee. And yet, when you go and buy your cup of coffee to £2.50, how much goes back to these guys and the kind of lives they're living? So anyway, going back to the visiting lecture programme, which is in Jima, these are the kind of key ingredients that have kind of come together. It almost sort of happened accidentally in a lot of ways. Because I saw the problems, because I've been going there for years with Operation Smile, I saw the problems that Yamania, an anaesthesiologist there, was having. And I said to him, look, I've got all these really keen trainees who would love to come and help out here, but I don't want to be a burden. I said, would you like them to come out? And he just jumped it. He said, look, we're desperate for people to come out to do training in anything out here. So we'd really love, the nurses need training, everyone needs training. So I said, okay, as long as it's not a burden, then we'll start thinking about it. So as all these ingredients are really quite key. We've got the local enthusiastic anaesthesiologist who can act as a local educational supervisor, or even teaching him to do things like workplace-based assessments, which is a bit sad, really. And I shouldn't say that as a TPD, should I? That's quite key that Jima University is actually wanting us to go there. They're actually asking us to go there, and they've got projects for us to do, and I think that's really important. We don't want to be going in there and saying, oh, we do it like this, so should you. We want to do what they want us to do. We're very fortunate in the anaesthetic in KSS Deanery in having an extremely great bunch of enthusiastic trainees who are keen to do it. We've had a very supportive head of school, Chris Carey, and of course, because I'm involved with all 3 areas, I know the site, I know everything that's going on there. It also helps that I can provide the mentorship from here. And the other thing which we've had small bursaries which have been incredibly useful for the trainees when they go out there to actually keep them ticking over, because they're going out there as UPs, not being paid, so that has actually helped quite a lot. And then the third partner, Operation Smile, we've got an office in Ethiopia with an Ethiopian person running that office. And because of that, we can get temporary medical licenses. We've got the infrastructure of a kind of big charity there. So if something goes wrong, you feel as though there's a bit of support there. And I think that infrastructure is really quite important. In the future, they also may provide some bursaries for us. And also because they're going there on a regular basis every 3 or 4 months, it means that they're seeing other people from the West going in and helping. So if you remove any of those elements, I think the whole scheme becomes quite difficult. So we set some expectations of what the visiting lecturers should do. We had a code of conduct, minimum of 1 month going there. I mean, I think probably the ideal amount of time is probably 3 months to 6 months. But realistically, we have to be realistic about that. But we have set an absolute minimum of 1 month. And we wouldn't send anyone who wouldn't be able to do what the hosting country, the hosting people wanted us to do. And I think that's really quite important, that you're not sending people into a position so that they're out of their depth. They send weekly reports back to me. Every Sunday night I get a report back from them, and they obviously do a report at the end of it, and there's meant to be a whole handover process, which is all in development. Okay, I put our first 7 lecturers up in, 4 of them are here today actually. I put our first 7 lecturers' names in lights actually, and I'm just going to go very quickly through sort of the impact we've had in Jima. But I think the biggest impact these guys have had is basically the professionalism, the compassion that they've had going out there, and their enthusiasm. And I think it's that the local people there have picked up on, and I think that's where it's made a real big difference, the professionalism particularly. And I think they've done a fantastic job. Of course, now they've got trainees out there, the more senior people. This is Yamani and the 2 anaesthesiologists out there. They can go and play tennis now because we've got the lecturers out there, so that's all right. The impact we've done, I'm not going to go through these in details, but we've set up a number of life support training sessions for the nurses, for the midwives. We've partnered with Lifebox and taken a whole load of Lifebox oximeters out there and done the training. A lot of the operating theatres in the small hospitals around Jima don't have any monitoring at all, so we'd be able to supply those and the training to go with it. We've brought in various guidelines, and we've done an awful lot of work on the ICU. Yamani out there was very keen that we did help out on the ICU because it's been a really big area, very, very much single-handed on there. One of the trainees felt that in the 3 months he was there, he managed to get the mortality rate on the ITU from 52% down to 33% by the time he left, so he was quite pleased with himself, but we haven't verified those figures for you. But we are collecting retrospective and prospective data on the kind of throughput in ITU. We've delivered obstetric anaesthetic courses where we've been teaching anaesthetists out there and also midwives, and Richard's going to talk more about that a bit later. With other partnerships we've had is with the Hong Kong Anaesthetics Society, where we put on a basics ICM course out there. So a few extra people went in and provided a course in basic ICU training for nurses and for their residents and interns. We're in the process of establishing a recovery area, which Callie's going to talk a bit about later. To think there's an operating theatre, they don't actually have a recovery area, so the patient, as soon as you go from theatre, just end up going straight back to the ward, which could actually just be a corridor. So actually, we've actually put in an actual recovery area there now and trained the nurses to go with it. The neonatal resuscitation, they just didn't do, and that has a huge impact. Just very basic neonatal resuscitation for the midwives, doctors, paediatricians, and we've even got our own house now. Last week we did a primary trauma care course, which was extremely successful, where we brought in surgeons, anaesthetists, and some nurses to work together in order to put together this kind of ATLS course for developing countries, which they will now, we've actually trained them to be instructors so that in the future they will do their own courses. So future plans, Annie's going to talk at the end mainly about the future plans, but I think the key thing that we brought it to this kind of forum was that we'd like to think that in the future they're desperate, as you saw from the beginning, for anyone from any specialties to be able to kind of provide training. And it was something that we just wondered, and we'll discuss later because you're all from different specialties, whether any other groups of people would be interested in getting involved with doing a similar thing. Because we've got the infrastructure in place and we can easily transfer it to different specialties. Right, I'm going to hand over to Richard now to tell us about his experiences as a visiting lecturer out there, to see what he got out of it.
Okay.
Right there.
Yeah, so quick little IT shuffle. Yep. There you go. Okay. So hopefully that'll work. says. There we go, brilliant. Okay, relief. So I'm going to try and whistle through this. This is covering the experience I had when I was out there in Jimma. Just a few photographs to maintain interest at the beginning. Ethiopia is a very mountainous, beautiful country, in contradiction to most of our images from it during the 1980s when it was stricken by famine. Covered in lots of luscious forest and water, lots of water. Very hard-working people in Ethiopia, and that's one of the things that struck me, and I'm sure it struck the other visiting lecturers when they were there. The commute to work can get you killed, more often than not, it does. You see lots of trauma coming in, the odd crocodile bite injury. A country steeped in religious history, both Muslims, certainly in the southwest in Jimma where we were, and also there's an immensely strong Christian heritage in Ethiopia that's caused lots of conflict over the years. But essentially, the Ethiopians are very warm, gracious, welcoming people, and it certainly made my time there all the more fulfilling. There were lots of things that all of us do when we're out there, but I'm going to focus, in the interest of brevity, on the maternity ward, where I spent most of my time. When I got out there, I met Yamani in the intensive care unit. That was my sort of rendezvous with a letter and a handshake of introduction. And Callie's going to talk a little bit more about intensive care when she does her talk. There was also a surgical mission with Operation Smile. It's another happy customer there. When I was out there, and that was 2 weeks of the 2-month period that I was out there for. And like I said, most of the things that I focused on were obstetrics and maternity related out there. This is a small group teaching session with Phil, who helped out on emergencies and obstetric anaesthesia. And that was teaching the midwives and nurse anaesthetists on various scenarios to help improve their clinical acumen. This is the maternity block from outside, so I wandered over from intensive care at the end of my first week to see what could be done over here, because John, my predecessor, hadn't had much chance to go over there. And when you walk through that front door, you're immediately struck by the smell. There's a mix of sort of fluid and feces all over the floor, because the toilets are right next to the front entrance. A bit sort of like something out of biblical times, or areas of South London. So I set about sort of going to work and finding out where I could be of help. The mortality in Jimma is immense, really. The national maternal mortality, and this was taken from figures in 2011, there's a sort of triennial survey that the government performs. 676 per 100,000 deliveries, which equates to roughly about 1%. And infant mortality, initially I just kept looking at this and people think it's a typo, but 30 to 60 babies dying every month, both within the hospital and within the town en route to hospital. And comparable to UK and Western figures, almost a third of deliveries are surgical. And most of them, I have to say, don't end in a good outcome for the baby. A lot of women in obstructed labour coming in with ruptured uteruses, and it's really life-saving by that point for the mother. This is a picture of the obstetric theatre. That's Baruch, one of the nurse anaesthetists in the top right-hand corner. And that was for one of these ruptured uteruses that came in. That was the first morning I was there in maternity unit. And I've put LLT at the top just to remind me, for those of you who aren't medical or midwife backgrounds or obstetric, that stands for left lateral tilt, which is a position you have to put the table in just to take the weight of the baby bump off the mummy's tummy, because that can interfere with her blood pressure and things. It's quite an important basic manoeuvre you do in all obstetric emergencies, and more often than not it can be life-saving, but they hadn't really registered the importance of that. So whilst they were doing fairly complex surgery, a lot of the basics that we take for granted were being omitted. Just a bit of a picture of the equipment they have to deal with. This is one of the life boxes that Phil and one of the charities bought out with them a few years ago. And most of the anaesthetists carry one of these around in their pockets if they're available or if the batteries are still working. And the monitor on the right, on the left rather, was just giving blood pressure readings. And it's an old halothane anaesthetic that they use. The resuscitaire for the little babies has seen better days, as I think you can see. And the anaesthetic drugs. And given the not infrequent short supply of them, I never had the courage to ask what the spanner was used for. So that's what they have to deal with. And this little chap, who was very helpful as well, anytime anyone yelled for suction, he would appear. I never got his real name, but everyone seemed to call him Suction Boy. The suction boy was a valuable member of the team. He'd run around clearing things up and bringing the equipment, and he sort of fixed equipment as well, sort of for those bits that were within his limits of experience. So given all of this chaos, really, relative chaos, I thought, how can I go about helping in this situation? Well, after these mothers, and Phil touched upon it earlier, wake up from their anaesthetic, if they wake up, they go through to one of the main wards. Half the time they're still breathing off the halothane anaesthetic gases. They haven't really woken up properly. They're wrapped in their blankets. They're taken back to this ward, which is understaffed by both doctors and midwives. And the family members, if they're lucky enough to have any, will be the ones that do their sort of main post-operative anaesthetic care. A lot of these women continue bleeding following their surgery, or they'd swallow their tongue, and go unnoticed sometimes for minutes, if not hours, that they'd expired on the ward. So I thought perhaps something like a post-anaesthetic care unit is the best way that we can make a big difference with relatively simple changes. So having had that idea, first of all, I needed to set about getting permission and a sanction from the powers that be at the university, find out a room and equipment and get some protocols and guidelines drawn up, and also disseminate that knowledge and that plan to the staff with training. So in terms of how I went about it, first of all, I spoke to the residents, the registrars in obstetrics. And they were very helpful. They were sort of people that seemed receptive to my presence there in terms of trying to change things. And they suggested I speak to Dr. Demisat, who was the head of the obstetrics department. So he was a consultant there. So I went and found Dr. Demisat in his office around the back of the maternity block. He was a very nice, smiley chap, but he suggested I speak to Mr. Fitson, who was the head midwife. So I went back round the corner, back into the maternity block and looked for this Mr. Fitson. He said, yes, that sounds like a great idea, but you need to speak to the midwives and nurses, who in turn, is the case seemingly the world over, actually controlled and ran the doctors. So the midwives and nurses went back to the residents and said, this is a good idea. And then in the middle of all of that, I had to go and find and speak to Dr. Haile Mariam, who was the head of education for maternity and other parts of the university, and Professor Abraham in his office, who's the dean. And then in the middle of that, get the anaesthetists involved as well. So there was a lot of communication and sort of going to mum and saying, Dad thinks it's a good idea, then going to Dad and saying, well, Mum thinks it's a good idea. It's playing people off against one another in a nice, benign way with the best intentions at heart. Just down the corridor from that theatre that you saw earlier was this storeroom, really a dumping ground, full of old shoes. That had a chicken in it that had been there weeks. And the theatre is just down the corridor through that door to the left, a general dumping ground for places and equipment that Suction Boy would sort of leave on a regular basis. So I thought this is probably the most seemingly obvious place to set up this recovery room. Around the back of maternity there was another storeroom, this place. We managed to rescue two relatively good-looking beds from there and find a couple of wheels to screw onto them. And then I set about in the evenings drawing up guidelines and protocols. So an observation chart that tried to keep it relatively simple, just things like, is the patient awake, are they breathing, are they bleeding? Those things that can be monitored without the need for equipment. And then directives on it for trigger points, for when they should go and get the attention of the obstetricians and the anaesthetists. On the back of that, the flip side, I put the Jimma WHO safety surgical checklist in the hope that if it's on one piece of paper, you can't have one without the other, and that would get incorporated into their practice. And all this took a lot of sort of, these are the protocols and guidelines for recovery, all of this took a lot of promotion, and also involving the people on the front line that were actually going to be doing it. So this is one of the weekly morning meetings with the midwives, so I told them about the recovery unit, and along with it, and the nurses did daily small group breakout sessions for neonatal resuscitation when I was out there as well, to try and improve those neonatal figures. Because there's no point trying to resuscitate an adult when you're out there. Once they're gone, they're gone. But neonates, in terms of potential to turn things around, had the greatest potential for success. So that's why we focused on that. And in addition, I had to draw up a new rota for the nurses, so they weren't going home too late at night or home too early in the morning when it was dark, but also to ensure that actually this recovery unit could be staffed properly at night, otherwise it was pointless in doing it. So then we had a pilot week, and within about 30 minutes of launching, that's the room that you saw before, the storeroom, we had our first patient. They came in, and then within about half an hour to an hour of that, we had our second patient. That's Mr. Fitsum on the right, the head midwife, with a couple of his nurses, and you can see the observation chart on the desk in front. So that was a great success the first couple of days, but it's only when you do these things that you realise the simple things that you take for granted back home. So on the chart I put sort of 0, 5, 10 minute observations, and I realised no one had any watches and half their mobile phones didn't work, so I had to go out to the local market and buy a clock. In terms of making these things sustainable, I think ownership and responsibility is a really important factor. So I could go out and do all of this, but unless I enthused them and made it feel like their project, as soon as I left, the chances of it just falling into disrepute again were exceedingly high. So I had an opening ceremony, tried to get the clinical director on the left there, Mr. Fitson, the head of midwifery, Yumani and all the midwives behind them, sort of involved as though it was their project. And put all of their names above the door and not my own. So that's the first ever WHO checklist along with the pilot week that we rolled out, which I'm told is still going, but I think probably sporadically in nature, showing the importance of having continued people out there to keep these projects going. Along with that and the neonatal resuscitation training, the new rota that Mr. Fitsum drew up with the help of me, the safe obstetric training courses, to name one, but a few of the training courses that the visiting lecturers have been involved with, and the successful use of this new recovery unit. People like Suction Boy became the left lateral tilt kid. Babies were being resuscitated properly, and I'm told from both other visiting lecturers and Ethiopians that are also on Facebook, funnily enough, tell me that this obstetric surgery recovery unit is still in use, which is great. So just to wrap things up, in terms of the benefits for me and the benefits for Jima University, one thing it did show me, and I think probably all of the visiting lecturers share this, is the importance of clinical governance. I think sometimes it's a bit of a thorn in our side over here in terms of extra work, but actually if you don't audit, if you don't look for near misses, if you don't look at how you can improve services, then that's a huge detriment to the provision of your local care. It taught me coping strategies with limited, often difficult resources, both pragmatic and emotional ones. Management and leadership. You're literally sort of, well, the first few of us were helicoptered in there almost, and dropped with just a brief of try and improve things, try and help with training, try and see how you can get involved. And that was a huge learning curve in terms of management, leadership, and building partnerships. But ultimately it taught me that all of that, it all just comes down to common sense and communication. You can have as many meetings and protocols and directors as you want, but if you get the right people in the right room with the right vision, you can achieve pretty much almost anything with a bit of hard work. And as Phil mentioned it as well, there's this potential to expand and diversify with this visiting lecturer scheme in terms of a broader range of healthcare professionals, not just anaesthetic doctors, other doctors, midwives, nurses on the intensive care unit would be invaluable. So that's it really from me. I think we'll probably save questions till the end. I think I'll hand over to Callie, who's going to talk to you about intensive care and other animals. Thanks very much.
Yeah, okay.
Hi, good afternoon. I'm Callie. I'm one of the registrars down in the South Coast as well. I'm currently based at Brighton. I got back from Jima just 2 months ago, and feels like it never happened now. It's one of those surreal dreams that hits you at the time and probably afterwards as well to a certain degree. I've done quite a lot of work abroad previously. I've worked in First World as well as developing healthcare systems, but I don't think actually anything prepared me for this 3-month adventure. So I left at the end of October last year, and it's quite self-directed, as you probably picked up from both Phil as well as Rich. We have a few places which I thought would be good to identify where I could help, but I was very, very keen to not intrude on what they had as their practice, but try and help along the way for their plans. So teaching, developing services, etc., but also approaching it sort of from different disciplines as well. So anaesthetics in Ethiopia, like Phil has touched on, is dramatically understaffed and pretty much underappreciated. Seeing as in Brighton there must be knocking on 50 consultant anaesthetists, there are 17 for the whole country out there, and that's medical anaesthesiologists who are supported by the from high school 3-year BSc anaesthetic staff. In Jima they're lucky, they've got 2 of the medical anaesthesiologists, and they've got about 11 BSc anaesthetists, but with a very different work ethic an attitude. Very much a work to all come in at 9 and they'll leave at 4:30 depending or not on what's going on. So quite a different attitude, and there's no additional specialist for ICU. So actually the medical anaesthesiologists have quite a lot on their plate. And at the minute, there's no registrars in training for that specialty. So my initial impressions, yes, it was hot, it was dusty, it was a bit crazy. I'd never really spent much time in Africa before, and certainly was what I was expecting to a certain degree. And days 1 and 2 at work, Monday I turned up, like Rich says, for an ICU ward round, all very civilised, and actually things went to plan. There is a coffee culture there. We stop at any given moment to go for a cup of coffee. There's an intern on the ward round who really doesn't look like they know where they fit in at all. The nurses were keen, the residents seemed in control, and then the Wednesday hit, Wicked Wednesday I'll call it, because that's when actually things changed, very much an eye-opener, and I realised that there's carnage here. We had 4 admissions to the ICU, all of whom were younger than me. 3 of the 4 died, and I'll tell you about one of the cases. It was pretty harsh reality, 31-year-old who'd had as a child rheumatic heart disease, and she had been on the medical ward in a corner with pending end-stage heart disease and failure. It was an unannounced arrival on ICU. There's no oxygen available on the ward, and actually on the intensive care unit it's just via cylinders, which need changing a lot. The patient was hypoxic, no oxygen on them, very much in distress. And really they arrived and the residents seemed to be completely thrown by this. There was no plan, no measured approach of care, and it was chaos. The drug that she needed to potentially change what was going on was £5 for 1 ampule, which is a lot of money. A lot of money for us, a lot of money certainly for an Ethiopian. And then to make it worse, this is how we got hold of the drug. So this is the intensive care unit. I had to get the intern to then write a prescription, which they did. The prescription's handed out through the window to the family, who then have to find the funds. Once they found the money, they have to run along the corridor, across the car park to the pharmacy, where they wait and then they get the drug, and then it comes all the way back, which takes a long time, as it turns out. And by the time we got the drug drawn up and started to go, 5 minutes later, the woman took her last breath. Pretty harsh reality. This was the patient drug drawer, as you see there's an egg in there as well, because that's really what we feed them through the feeding tube to their stomach as well. So I realised 3 months was going to be a pretty short time, and I wondered where I could fit in and help here. And these were my main objectives. This is Dr. Yamani, who's really my mentor out there, and was keen for me to help there. And these were the 4 things that I thought. 3 at work, the life skills I'll come to later. So teaching and education, on the right are the sort of things that I did, but I won't focus too much on that, but very much getting used to teaching a different crowd. They're really proud, the Ethiopians, and like a lot of people, don't want to admit what they might not know. So quite shy to contribute initially, and very much I realised that they were great in smaller groups, and that seemed to work. Terrible at timekeeping, I'd say 2 and 2:45 everyone would turn up, but that's fine. But we did do regular teaching, certainly for those interns, which I thought would also key in to trying to recruit anaesthesiologists for the future. And I used to teach them on Tuesdays and Thursday evenings every week, and there were 2 the first week, there were 5 the second week, and we kept on gathering momentum, and it was satisfying. I also tried to teach on the ICU in the afternoons, just to mainly focus on priorities as well, clinical approach, etc. Like Richard's talked about, improving services, it was very obvious that there was an absence of a recovery unit for main theatres. There's 3 theatres, 1 for trauma, 1 for emergencies and 1 for general surgery, and there's no recovery unit. And real issues of patient safety. Patients return to the ward with a very long-acting halothane gas on board, often in pain, and with just an intern and a nurse looking after them, certainly dangerous at night, let alone during the day or when things are busy. It also would benefit surgical efficacy and the throughput. So that really was a challenge. On the right is what I did, but I won't dwell on that, because actually the challenges I faced was that logistics in a foreign environment, who do you talk to, where do you start, who's the best person, and like Rich said, where do I start to keep it politically fine? I don't want to tread on toes, I want to just help. And it's quite difficult. By the Ethiopians' own admission, they need pushing. They need pushing, they need more pushing. Because they're keen to help, but they need reminding of what we're aiming for. And then things like suction, trying to get a new suction unit to finance, get that financed and delivered that again causes the logistics. It was a project that I started, handed over to Graham, who's there, and I've been told it opened 2 weeks ago, which is a great relief. And finally, the clinical work was absolutely fascinating. Some of the stuff that I saw was something I'd never see. A man who had an ox horn in his head who developed cutaneous anthrax. I can't imagine I'm going to see that in Brighton. Gunshot wounds through the neck. Babies in extremis with different syndromes to cause a challenge as well, but great teaching there as well for both the residents as well as me. End stage sepsis, eclampsia, fulminant polytrauma. And then the life skills. While I was out there, I was very keen to get absorbed in the culture. I was the one who found a house out there, which actually added to survival skills, as it were. The resources are short. We went for 9 days without water on the ICU and at home. You kind of get used to it in a kind of understanding way. Everyone's in the same boat, but it does make you realise what we have and what we can cope without. I didn't have much contact with the outside world as far as the UK goes. You do become adapting and resilience. One Sunday afternoon, this chap here, a middle-aged man, turned up at my front gate with a machete in his hand. I did think it was the day of my last, but he'd come to cut my grass. My neighbour had organised it, fine. You get used to things like that. I had, and survival skills, I was able to kill a chicken and a pig by the end of it. I'm not sure whether that's a good thing or not. But you meet some amazing people here, and I think that's what's also impressive. And this was the hospital security that used to continuously run along the top of the ICU. So things that I gained, I think this is remote anaesthesia. You are on your own, and you do start to adapt your practice to fit with what's needed, and there's limited resources. I think there were definite cultural approaches to sickness, to death, and I can see why, and I certainly adapted my behaviour towards death and sickness during just that short 3 months, but it's good to learn. The teaching was brilliant, yes, leadership and management, and also the exposure to the medical side of things, to the extremes of pathology, and using my hands, my ears and my eyes again. I did a full neurological examination, probably for the first time in a long time, because you can't CT everyone's head. And for my sins, I'd never quite understand how clinical governance and audit actually does fit in, and safety pathways, and it was very obvious why they're vital to our healthcare system. And then secondly, I hope that Jima has gained from my 3 months there. I really tried to create an open and enthusiastic teaching programme, and to show a method of prioritising patients and how we manage, how we triage, etc. And I think it's definitely a mutually beneficial relationship with the visiting lecturers. And I managed to travel. My God, it's a beautiful country. Anyone who wants to go, go, because it's fascinating. And the more you delve, the more you realise. So a few summaries. I think it's probably similar to what Rich said. It's back to basic stuff, but you do form a resilience and a self-reliance there. And initiating change can be difficult, but managing it in different cultural places is perfect. Thank you very much.
So, hello, I'm Ali. I was another of the visiting lecturers who was out in Jima in October last year, but I also have just returned with Phil actually a couple of weeks ago, running the primary trauma care course, but also trying to develop the visiting lecturer programme while I was out there. So I'm just going to briefly go through the current setup. I know we've already spoken a little bit about that from the fantastic presentations we've had so far, but then talk about how we're actually going to set up a HEKSS and Jimma link, and how that can then be incorporated into other specialty programmes. So our current setup started in August 2012, and as Phil mentioned, it didn't really have a structure. It just kind of happened because of the enthusiasm from trainees wanting to go out there. The funding kindly came from the KSS Deanery with bursaries, and that funding is due to run out in February 2015. So we're now going to have to try and think of other ways in order to get money to send our visiting lecturers out to Jima. Projects have been established by each individual, creativity when they go out there, as already mentioned with the recovery, both for theatres and maternity, but also all the ITU projects, the neonatal projects that have been going out there and have been very successful. The courses, the SAFE, the basics, the PTC have all been run very successfully, and they're going to continue. The recent PTC course has actually been asked to be incorporated into their curriculum for all of the surgical trainees, which just shows how successful it's been. Now, we sort of see this as phase one. We're now established in the community with the visiting lecturer house that Callie set up so well, and I stayed there myself 2 weeks ago. We're not only in the community, we're in the hospital. They know us. We're present, and then we've got a continuous presence there now. We're not just in the ITU, we're in trauma, we're in theatres. They don't have an accident and emergency department, they have an emergency OPD, which is very basic, and we're now trying to get into there and sort out triage in that system. So we want to know where we could go on from there, because the current structure couldn't really be continued. And while I was out there, I had meetings with the heads of various departments, including Dr. Yamano, the anaesthesiologist who you saw in the presentations from Richard and Callie. And he's really worried that it's not going to continue because we don't have a sort of sustained future link. So I went to the Dean of the university, who is Professor Abraham, and again, very aware that we don't want to impose ourselves, said, do you know about our visiting lecturer programme? He said, yes, it's great, it's working really well. We've got a new hospital, we need to fill it with personnel who are trained. We don't want to send people away to other countries because they go away and then they don't come back because it's better opportunities for them. So the visiting lecturer programme, if you can roll that out to other specialties, get them to come over and help us, he would love to. And he said, let's sign a memorandum of understanding so that we can actually link KSS with Jimma University. So what is a link? Well, THET, which is the Tropical Health Education Trust, say that it's a formalised voluntary partnership where people work together to share ideas, knowledge and friendship to improve healthcare. Now, the primary aim is obviously to increase capacity over in that developing country, but don't think that doesn't actually benefit us. And I think you can quite clearly see from Richard and from Callie that actually our clinical skills improve immensely while we're out there, having to go back to basics, learning resilience, adaptability, problem-solving skills, and seeing cases that you just wouldn't see in the UK. Not only that, the wider skills, management, leadership, for example, all very much transferable back to the curriculum in the UK for us trainees and for the NHS. So these are sort of potential areas that a link can be beneficial. So their postgraduate training, I discovered while I was out there, is pretty much non-existent. Surgeons have a 4-year training programme and medicine is 3 years, but they need curriculum actually writing for them because they don't actually have it. And the curriculum development is something that we're doing with the anaesthetic department for the anesthesiologist residents, but we need that for nurses as well. The ICU nurses don't get any extra training, they don't get any extra pay, but they're just expected to do a job that is far more advanced than the nurses on the ward. Also strengthening current collaborations that are out there that we've mentioned, and introducing technology, equipment when we go out there also. So we want to set up a partnership that will give some security to the visiting lecturer programme from their point of view so that we're not going to leave. It gives structure to our programme, and we will be formalising the anaesthetic training programme, and actually in the memorandum of understanding we will be actually able to examine those residents, so we will be part of the process. We will then be applying for funding through DFID and THET and other charitable organisations in order to fund the projects that we are doing, because funding for this is starting to dry up. But we've understood from being out there that actually a multidisciplinary approach to the visiting lecturer programme means that the projects that we do run and the courses that we run much more successfully. And we want to open that up to others in KSS, and we call that phase 2. So the current collaborations that we have with Operation Smile, who do missions regularly and were out there a couple of weeks ago, Lifebox, the charity that gives out pulse oximeters that you saw in Richard's talk, GoStar, which is a Swiss charity which send out trauma surgeons, physiotherapists, who we've worked alongside in theatres and during the primary trauma care course. Peace Corps, there's loads of Peace Corps volunteers out there, and they are a huge support from the community side of things. They're also in the community all throughout Ethiopia and are called upon to bring patients for Operation Smile, so it's a very good relationship. Nottingham University has a link with Jimma, and they're actually going out in a couple of weeks' time to help on the ICU, but by using the visiting lecturer that we have now, Graham, who's out there, he's contacted them a few weeks before so that they can actually set up a good project while they're there to make their time worthwhile. Munich University has a good link. There's been a microbiologist who's been out there for a year who's just been amazing, and I don't know what Jim's going to do without him when he's left. And as I mentioned, the Primary Trauma Care Foundation, and that course works so well, I think, because 4 of the 5 faculty had either worked in Jimma or are currently working out there. So there's buy-in, they respect Michael the surgeon and Phil, who's been going out there for many years. So we need you. We need other people to help us essentially build this multidisciplinary visiting lecturer programme. The plastic surgeon who Phil mentioned already, Per Hall, who has actually set up a Jimma plastics programme for the surgical trainees, he's seen our programme and seen how successful it is, and he's actually setting up a visiting lecturer programme for plastic surgeons, which within KSS, East Grinstead, it would work very well, and that's through East Anglian Deanery, which hopefully will start in 2015. But we don't just need doctors, we need nurses, physiotherapists, ODPs, biomedical scientists, research fellows, medical students. Everyone can be useful, and we've kind of seen from going out there that actually having a team approach to this makes such a difference, and it will benefit not just Jimma but also KSS and the NHS as a whole. So if anyone is interested, please feel free to email myself or Phil, and there is actually an information sheet that's over by the door if anyone wants to take one of those, and we're all open now to questions. Thank you.
Any questions at all for any of us?
Just, I'm trying to think whether it's a question or a comment. I'm really interested in this. I think it seems to me to fulfil lots of issues that we talked about this morning in terms of how we start to get different experiences, how to get people to come together. You probably recognise that I'm the Director of Education and Quality for Surrey and Sussex, and sort of in my head I'm thinking things like, some of the fellowships that we funded as a collaborative, really. It's certainly worth us looking at how this might fit in.
Do you see, you think it's a possibility, that it's something that the Deanery may support?
It's extraordinarily valuable, and I think, again, we're developing at the moment. I think Jeff's sitting there, a sort of professional strategy unit. And it seems to me that there is, I know in my last role as Integrated Director of Education, things that sort of sat outside of the box around things that we wanted to do. There are sort of often ways around them. So things like, we used to set up things like chief exec bursaries and stuff. So I don't know, I would say that I'd be interested in having more of a conversation.
Yeah, no, that'd be great. Yeah, that'd be
so
really, really.
Tie in some of the priorities. Teamwork, it seems to me to be. So I just want to say, well done, fantastic work, really. Very, very good. So yeah.
Thank you for that. Thank you.
Come down.
Yeah, we'll arrange a meeting and have a chat about it.
Just ask, I'm Kim Stillman, GP Associate based in East Kent, with responsibility for Midwife. We, for a number of years as GP trainers, sponsored a project in Tigray, in Ethiopia, in primary care. Now, I've not been out on that project. I don't know, have you been out on it? a lot of people in East Kent have been involved with that. It's also multi-professional. And I'm just wondering, not knowing the geography, does that have any links? And
I'm not sure where
It's
Tigray is.
very far
Tigray is
north.
north.
Very north,
Yeah,
right.
it's
so,
north.
so it's a long way. Yeah, but it seems interesting that within KSS there are these
Absolutely.
two initiatives. It might be worth
And
keeping in touch.
yes, I think that's a very good idea. Is it GPs or GP trainees that are tending to go out? Or?
It's currently, at the moment, it's not. It's established healthcare professionals. So it's GPs, but some hospital colleagues have also been out. So I know it's actually managed through primary care, but we've sent out midwives, paediatricians, as well as primary care. So I think our input as GPs is very much public health. But if
Right.
you're thinking of expanding it, just
Yeah,
seems
absolutely.
that
I think that would be. I
Yeah.
think we should
there
definitely.
might be
Yeah,
a line of
definitely.
communication.
Yeah.
Because I'm also interested as to whether we can put medical students into the project.
Well, interestingly, we've had a medical student who went out there about 3 or 4 years ago and did an elective there for 8 weeks, and it was very successful actually.
Yeah.
So it went very well.
We've
Because-
had very positive feedback with the same organisation based in India. So
Yeah.
I mean, Phil, there are other links. I mean, in psychiatry, for example, the deanery links with Ghana, through Peter Hughes at St George's, and that's very much a teaching. It's not particularly to do with service delivery, but it's to teach community psychiatric nurses and the very few psychiatrists there are there, the basics of management of.
So do you go out basically as a kind of?
The higher trainees go, yes.
And then they go out there for a period of
Yeah.
time or for a week?
Yeah,
or
no,
for a period of time.
Yeah, 2 or 3 months.
It's interesting, isn't it? All these
Yeah.
things come out of the woodwork,
But I think-
and this is one of the reasons we did this, in
I
order
think
to
it's-
stimulate
yeah.
this kind of discussion. I mean,
In psychiatry, I think I suppose the focus has been where you have no psychiatrists, then you want to train up nurses, often general nurses, in the kind of basics. So they acquire sort of how you use one antidepressant, one antipsychotic, and one mood stabilizer to manage the whole array of psychiatric morbidity. Because I think the thinking is that a psychiatric nurse is better than nothing.
yes, absolutely.
And
A
it's
lot
worth
better than
quite
nothing.
paying.
But I think it's quite interesting, isn't it? Because all these projects, I mean, should we be in a place where we should be actually making a group of people who are doing these projects so that the deanery knows what everyone's doing, and it would actually be possibly quite useful to put something like that together.
Hi, I'm Ali Bakari. I'm a DME at Dartford and paediatrician, so I'll be very happy to support you in any way we can. But do you already have a plan of engaging with the specialty schools or whatever, or is it something that you could create a network for? Because considering that we have a number of colleagues who are interested in either having established training programs that, or specialists who go out there, or at least interested in it. Is it worthwhile as considering a network?
Well, that's right. That's what we're saying. Basically, building a network, because I mean that's why we're here, because we're doing this within anaesthesia, but clearly there's so much other specialties could give to the program, and actually having a link with a particular place. I know people have got their own links, whatever, and adding in, paediatricians going out. There's a house there with a couple of spare rooms in it. In all seriousness, those things are actually really quite important, and you've going into an infrastructure. I mean, when we've been out there, for example, last year there was a paediatrician from VSO who was out there for 6 months, and there's a lot of linkage between that. So it'd be nice if your specialty would be interested potentially in
So what I was really trying to get is what infrastructure here, I don't mean infrastructure there, will support this building of network. How will you build that up? So, for example, at the HEKSS level, we have a DME group that meets, and potentially that could be an area where you meet, heads of specialty schools meet. So I'm just thinking of what structure there will be that will support this network.
That's where we're starting out. So when I went out a couple of weeks ago, I was just getting interest from the other specialties while we were out there, and I met with the head of paediatrics, Dr. Netzanet, who said we would love a visiting lecturer. We've got 22 senior posts, they're filled by 8 consultants essentially. They've got no protocols, they've got no curriculum, and they desperately need people. So this is kind of a fact-finding mission, and then this was a very much, is there interest from other people? Because we had a meeting last night of all the visiting lecturers, and we talked about setting up a committee and a structure, as you're saying, and we need to go through the right channels to formalise the link with them and with KSS to make sure that we do it successfully. But yes, absolutely, once we know if there are other people that are interested, we can put all of that in place, because it would be fantastic if, for example, paediatrics were interested. Thank you.
Great. I just think what you're doing is amazing, and I'm not from KSS, so I can say this from the outside, but fantastic stories about relatively, what feel to you relatively simple things that you've done that will be really, really transformational locally. I'm just still concerned about the sort of intrinsic capacity thing, and I was curious at your comment that they've gone from 3 to 14 medical schools or something and I don't understand that. Where's the kind of faculty that supports that?
Well, I've been asking the same question, and that is, one can imagine the quality of the doctors that are potentially getting produced. And I think it's become very, classroom-based learning. They put a whole load of people into a lecture room and lecture them and say, you're a doctor. I'm just simplifying it, but I don't know, and that's why whenever we're out there, they're constantly asking for people to come out and help do the teaching, because they don't have the capacity to do the teaching. I don't know how they've done that. I have asked that question many times, and I can't get a proper answer to it. The bottom line is they've recognised that there is a need to have healthcare professionals, and they're trying to do it in an exponential way, which we could never have conceived in this country. It's just been a gradual build-up, but they're trying to go from that level to that level, in one jump, and it's very difficult. It is a huge challenge. And interestingly, the people who come out, you see the quality of the surgeons, despite the fact that the limited amount of experience, they've got a massive experience because they're working all the time, but without supervision, and therefore structured training. They do what they can do. They will do a basically neurosurgery, which is a burr hole. They'll get taught how to do that as a first-year surgical resident, like our surgical residents might get taught how to do an appendix. That's the kind of thing that they're doing. So they're jumping very rapidly with great skills, but without a kind of educational structure, without systems in place.
No, I just think because my experience is a little bit in South Africa, a little bit in Fiji, and a little bit in Tanzania, and they're all in very different places and have taken quite different approaches. But and I haven't been deeply involved in any of it, just peripherally, but this just felt to me like such a big jump in one go, and they must desperately appreciate you guys. You must be like gold dust. But how do you create consistency? How do you create something that's enduring there? It's going to be a huge challenge.
I think the thing that we've found is by the consistency of having someone there. They know we're coming. They know there's someone there all the time, and they've seen. I've been going for donkey's years through Operation Smile through another group, but they see us coming back, and then you earn your credibility, I guess. And these guys have been fantastic ambassadors for KSS and the medical profession in this country, because they've earned amazing credibility for what they're doing. I think we're probably being pushed. Okay.